Okay.
So good evening, everybody. Just as a quick reminder, as people join, just make sure you're muted. Just if we have a few coughing noises in and around, it makes it a bit difficult for the speakers. So I was just going to start by welcoming everybody. My name is Richard Shaw, and we're on the third of our 6 lectures as part of our RED education. So it's research education development, the RED lectures from Liverpool Head and Neck Centre. So I was just going to announce next week's while everybody joins. So next week's we'll be joined by Dr. Yvonne Daly, Dr. Deborah Moore, who are both involved in dental public health. And they've got a particular interest in some new data on the incidence and mortality of head and neck cancer, and have particular interest in social inequalities and how that interacts with head and neck cancer, which makes for interesting and quite disturbing data to view. And I think it's really important, that lecture. So, but back to this evening, and I'm going to just share and introduce Vin, who is waiting patiently. A friend and colleague, Vin Paleri. Vin, I've known for many years. Vin started his consultant career in Newcastle, and a few years ago moved down to the Institute of Cancer Research. Vin is a distinguished clinical academic, and a quick flick through PubMed tonight revealed that Vin's published 226 papers, and that's only ever an underestimate. And he'd actually delivered quite a lot of trials and clinical research studies from a primarily clinical position he had in Newcastle. So when he moved to the Marsden and the Institute of Cancer Research, you would expect his research to really blossom. And in fact, that's been the case. And Vin now leads a program grant called Everest, which is about the presentation and referral of head and neck cancer, and has several £1 million of grant income. So Vin today is going to talk about a different interest to that. He's going to talk to us about recurrent head and neck cancer and how we can progress it, which up until that point, I would say was a desperately unfashionable subject for a surgeon to be involved in, and he's kind of made it his own. So with that, I'm going to stop sharing and introduce Vin and ask him to share screen.
Thanks, Richard. Thank you for the invite. Very kind of you. Footsteps of Simon Rogers and Christian Ottensmeyer and Joe Patterson. So I'll try and do justice to this talk. It is a difficult topic to speak on from a surgical perspective, but I shall try and do my best. I'm going to share screens shortly. My connection, I'm actually not at home, folks, so my connection is slightly unstable, but we should get through this. Okay, let's see if this works. Okay. If things are good, that should be coming through.
That's good, Vin.
Amazing. Okay, so that's the title of my talk. Let me minimize this too. Which way does progress lie? I have a conflict of interest. I'm Proctor for Intuitive Surgical, the company that makes surgical robots, and also a consultant for CMR, our homegrown company that makes medical robots. So I'm going to kick off with perhaps 3 questions. 3 questions to which you'll be quite amazed to know, audience, that when I show these questions to a live audience consistently, the response is split 50-50. Can you hear me?
We can, Vin. I'll just remind everybody to mute their microphones unless it's yourself, Vin, of course.
So these are the 3 questions. For example, when I put this up to a live audience, I kid you not, people think if the expectation of a clear margin is less than 5 millimeters, you should not offer the patient salvage surgery. People think, 50% of the audience think that you shouldn't offer salvage surgery if adjuvant options aren't possible. For example, re-radiation or chemotherapy or immunotherapy. It's reality. People think that these are operations with no oncologic efficacy. So we really have a conundrum here. We have a problem where we have a group of patients who have had a complex disease. The numbers are small, but the general impression from the population that treats these patients is that perhaps these patients cannot be salvaged. They can't be offered treatment with curative intent. I'm going to change the story slightly and demonstrate how we can do things differently. And that's simply because the field is changing, treatments are changing, the narrative is changing. Undergoes salvage procedures, not just surgery. I'll come on to other non-surgical things in a bit, but they are doing well for a longer period of time. This is Russell. I have Russell's full permission to show his picture and tell his story as well. He was diagnosed with neurohypopharyngeal cancer way back in 2019, received standard of care, concurrent platinum-based chemoradiation therapy, did well, a routine PET scan shown primary site uptake, but this is 3 months after his chemoradiation, showed two metastatic foci in the liver. So these were fairly small. So when I was training, and even until relatively recently, these would an indication for putting the patient down to a palliative supportive care route. So we discussed it with MDT, confirmed it's SCC, but then he was pushing and he underwent laparoscopic resection of this small volume disease. Depending on the segment, you can do that for liver, and he got away with it. The CPS, the combined positive score, of more than 20. He underwent pembro chemo combo for a couple of years after that. So he's now 2024, November 2024. He is now 5 years down the line from his orohypopharyngeal squamous cell cancer, which was diagnosed in 2019 to have liver mets. So that is something unheard of. And I kid you not, we get this on a regular basis at the Marsden. So someone's been through an Aspen trial, they've done well, they get a chest met, we put them on something, the chest met goes away, recurrence comes back locally, we salvage them.
Like care, not good refer them.
Someone speaking, could you mute your microphone, please? Thank you. So I think there's a real need to rethink the whole process. So what are the pragmatic options for progress here? It's a rare tumor, we get that. But the bigger issue is that we lack robust baseline data here. There is heterogeneity in management. Surgical trials are difficult in this space. I will talk about how oncological trials have done really well here. So what we thought we should do, how to approach this, is to acquire good quality population level data to understand the scale of the problem, to generate consensus in management, because consensus is very, very varied in this space. We regularly get patients who are told nothing more can be done, who are offered best supportive care, who on the contrary can undergo salvage surgery, or there are options available which are standard of care. So consensus generation is key here. And of course, collaborative work will help us understand the biology and perform prospective studies. So I'm going to speak on these three broad headings over the next 20 minutes or so that we have left. So to define population-based data, we think it's possible. Population-level data is possible. This is Fudge. Fudge is my PhD student who's now working on a project called Search a Head and Neck, which is where we are using linked national data sets to understand the landscape of recurrent head and neck cancer in England. I know Scotland's not there, I know Wales is not there, but we are trying to integrate this in a later phase of the process. So as things stand now, within England, we have 9 isolated data sets. They're not isolated, but these are data sets which collect certain elements of data. These can be linked at the patient level by using NCRAS, and that is feasible. We've done some work on this in the past for primary cancer, and we've demonstrated that's feasible, and Fudge is going to work on this. I'll show you some examples. But our intention is to estimate the recurrence rate after curative treatment for head and neck cancer, to define patterns of recurrence, and to capture the variation in treatment of recurrence and surveillance, et cetera, so that we can move this field forward a bit more. So we got 4 phases of methodology. I won't bore you with that, but essentially we're going to collect loads of data. We're going to develop clinical rule-based indicators for this data, and then we'll extend it to other sites in addition to, let's say, larynx or oral cavity to understand this and perform a whole lot of validation. All that's been done, a few other cancers. I'm going to demonstrate a couple of examples and some principles show what exactly we intend to do. So phase 1 is to define the study cohort, and that can be done using the codes we have, the ICD codes that are well available for this purpose. We link the data sets and we then join them up at the patient level and figure out what needs to be done. Let's take an example. So here's a patient who comes in. I'm going to use my pointer. Apologies, folks. Okay, so when a patient comes in, they get diagnosed with the problem, with the cancer, and HES picks up an ICD code. The patient has intervention, let's say it's surgical intervention, they have an OPCS code that pops up. They have radiation therapy, the RTDS picks them up. They have chemotherapy, SACT picks them up, and so on and so forth. Once the treatment is done, they perhaps have a PET scan. They have further imaging. The DIDS picks them up. So every time the patient has a diagnostic intervention or a surgical intervention or an oncological intervention, they ping up on the national data sets. Let's say this patient then undergoes follow-up at a later stage. They ping up in the outpatient clinics on a regular basis. Suddenly, let's say 2 years later, more scans pop up, more interventions pop up, and more outpatient appointments pop up. That indicates that patients at recurrence. So you can pick up these dynamic phenomics within the national data sets and link them all up at the patient level. And this has been done for other cancers. This, for instance, is an example in colorectal cancer. You can see that the patient comes in initially with a cancer. The patient has outpatient appointment there. They have further imaging on the DID registry, they crop up there. They go on to have a diagnostic procedure, and that comes up in the pathology data set. They start chemoradiation therapy. They pop up in the SACT and the RTDS data set. Carry on, they have a surgical resection, and there's the admitted patient care episode, APC. They're in hospital for a while. And then comes regular outpatient appointments. You see that happening serially as outpatient attendances. And you get intermittent scans that are picked up in the DID. About here, 36 months later, the cancer recurs, and see what happens here. The patient gets more intense DID appointments. They start getting chemotherapy here. They get radiation therapy. There is another admitted care episode for a colostomy maybe. So you can make out these things if we join them up at the patient level. And that's what we're doing. So what we've done so far is we now have data from close to from 8 years of data that's been accrued across the 9 data sets. We have now defined in the first instance on the primary site where the patients are treated. We have that picture, and we're slowly developing the picture for primary cancer and then generating that into recurrent cancer field. So we made a fair amount of progress, and a paper will be presented, a couple of papers will be presented at Barno. I don't want to take away my PhD candidate's thunder, but there is some good content validity in the work that she's done so far. So that's population level. How about consensus? How can we generate consensus? Consensus for recurrent cancer is really poor. So this is a fairly relatively recent paper that assessed agreed to protocol, and it demonstrated that almost all of them have low or average quality. And we've had some experience with Delphi process. So we thought we should perhaps work up something along these lines. So what we did was we started working on the consensus document from IREC. IREC is the International Center for Recurrent Head and Neck Cancer that the Marsden charity supports, along with some other portfolio funded money. And Andrew Williamson, my current PhD student, was allocated this piece of work, and he has clearly delivered in spades. So what we did was we defined the recommendation across existing practice guidelines. We looked at the systematic reviews that were there. We identified gaps and performed from our unit 2 bespoke systematic reviews to pick out data. As you can imagine, you don't have a great deal of randomized control trial data in this space, and therefore we had to rely mostly on systematic reviews and other review articles. But the bespoke systematic reviews helped us plug the gap that was evident. So we used Agree protocol to set out our consensus process, and Agree is a framework for guidelines, essentially the Agree to protocol. I forget the acronym for that. We use the strength of recommendations taxonomy to make the recommendations so that what we're recommending is very clear, explicit, and that is based on the literature and the evidence being provided, and also rhymes a bit with a nice language. So we did the Delphi survey. I won't bore you with this. And these are the thresholds we set, and the thresholds are based on the RCR consensus statements. And these are a good way of defining thresholds when you're performing a Delphi process. So we had support, broad support from ENT UK, from Barno, from BOMS, the 3 key organizations involved in this. Remember that we didn't go for the oncological side of things, and that's because most of the statements we worked on were surgical and supportive, best supportive care statements, and of course in allied health practice. So we generated the statements. These were very carefully curated using Agree and SORT, and went to these organizations. They recommended experts, so we got the experts in, and the experts represented 15 departments across England and Scotland. And we finally came up with 73 best practice statements across 4 subsections for the IREC consensus document. So you can see how a statement reads. It follows the nice recommendations for language. We use the SORT taxonomy. We use the RCR thresholds. And of course, for each statement, we explicitly say where the data comes from and offer that information too. And we went through a couple of phases, and I won't bore you with that, but essentially this is what the guidelines look like. So this has been sent away for publication. It's been presented at Barno last year by Andrew Williamson, and it makes for pretty decent reading. You can go through it relatively easily, and it gives you very clear recommendations on what can be done, what can't be done, and the level of agreement, so that you can see how much of that you can apply to your own institution. So that's the consensus bit we've done. And of course, collaborative work is so important in the space, and we kept that completely, which is why we thought, let's dip our toe in the water and see if we can do something on a large scale collaboratively in a relatively rarely explored intervention. So we went international with this, and we looked at the utility of robotic surgery in the setting of recurrent oropharyngeal cancer. And we got good buy-in, and we demonstrated across 300 patients that you can get pretty decent outcomes that are comparable to open surgery in this space. And John Hardman led on this particular piece of work, and he's now a fellow overseas, hoping to come back to UK. The Recurrent study demonstrated very clearly that it is feasible to perform minimally invasive procedure and get great outcomes, and this can be replicated across multiple centers internationally in this particular space, as long as you chose the patients well. So just to confirm, that's what we demonstrated with TOS. I'm just going through a whistle-stop tour of what's feasible when we collaborate well. We're now working on the SCORE study, and the SCORE is designed to define what would be an appropriate margin for transoral robotic surgery. Millimeters, what we use as by default. 3 millimeters is acceptable across most units, given the restrictions we have in the oropharynx in this particular space. But we don't. But this is all arbitrary. This isn't based on any high level evidence. And SCORE was commenced with that particular outcome measure in mind, and we now have made good progress with that, with a number of universities and academic institutions offering to help with this process. We have 20 centers in setup, are open, and more than 30 centers who have agreed to participate. So it's hard work getting the data sharing agreement, getting the collaboration done, but because we demonstrated in Recurrent that it's feasible, we went for broke with SCORE. So with all this progress, we thought certainly something more can be done because there is so much appetite for this. There is so much collaborative expertise available to us. And we set up the International Center for Recurrent Head and Neck Cancer. And these are the 5 aims of the center. It's a virtual center. It's not a physical center. But the aim is to define the understanding, create international networks for research delivery, and develop a mechanism for seamless fundamental science, translational research, and explore cancer survivorship issues. I won't bore you with this, but that is essentially a breakdown of the aims into objectives. Maintain studies in progress across the domains of both head and neck cancer, squamous cancer, and thyroid cancer. We have nothing on salivary cancer or the other rarer cancers. I'll take you through a couple of them, which are essentially based on network and collaboration, which is because that's the theme here. So we now have established our network, and Liverpool is one of the centers. And within the network, the aim is to for each center within the network to offer information about the recurrent cancers they treat, and of course have a collaborative agreement so that we can concurrently run studies without every time going through the painful process of opening it up at each center. So collaboration agreement, just like Cancer Medicine Network for pediatric and adult cancers, just the way they do it, we mirrored this on the ECMC network's collaboration agreement so that you can kick off a study in one center and seamlessly, with relatively less pain, open at multiple centers. And these clinicians have very kindly agreed to participate and have given us generously their time. And we have a couple of studies that are cross-center now. Rescue has commenced. This is the first study looking at salvage surgery in this particular setting. And Rescue's now recruited 130 retrospective cases and about 25 prospective across the network. So that's going pretty reasonably well. And of course, we collect tissue, and that will form a good background basis for further research. And the fundamental science is led by Ben O'Leary, who many of you may know is one of our clinical oncologist colleagues, but also a clinician scientist. And we have tons of work going on in that space. For example, one is Art Deco Translational, where we have the tissue of all patients who were recruited to the Art Deco trial, which is the dose escalation study for larynx hypopharynx cancer. And we're looking for genomic transcriptomic signatures. And of course, we collaborate on a couple of other studies with overseas centers too. So there's a fair amount of work going on. And of course, an integral part of this is the IREC Biobank and Registry. The 9 network centers will contribute to the registry because we pay for data managers in those registry centers. Biobank is a different thing. Biobank, clearly, transfer of tissues is slightly more arduous, so we're working on it. But as things stand now, we have a biobank within the Marsden for recurrent cancer patients we treat here. And of course, the registry is so important. Being a relatively rarer disease, it may be impossible to run a surgical trial in this space, but you all know that you can run registry-based randomized trials. So the expectation is that a registry will form a firm foundation for us to work more collaboratively in this space. If all 9 centers offer information on their patients, that of course leads to significant benefit. And this registry will be tagged on to the Liverpool registry that is coming online very soon. So the recurrent cancer data set and the data points will be contributed to by IREC. And of course, there's a primary cancer that you're working on. So we have a seamless registry that's based on the same spine and working with Arrow in this space. And we have generated funds for the recurrent cancer piece of work. On the cancer survivorship side, we just had this particular piece of work over the last 3 years, and my colleague Gronier published this, and this is now in JAMA Otolaryngology just as of last week. And we have really understood in depth what exactly patients with recurrent cancer want and what they are willing to trade off in this particular space. So I'd let you read the abstract. I won't dwell on, but this has given us a real direction of travel for treating our patients. We have approached international centers. Again, it's not easy, but work is in progress. But we're specifically looking for centers that that complement what we can't do within the UK. For example, we want more oral cavity recurrences, nasopharynx recurrences. That's the way we have decided to engage with international centers. We've had some substantial early wins with this approach. We can see here what we have had, especially the part of the BRC application was helped by IREC's contribution, and Ben's won a welcome fellowship recently. This was last month. So clearly, the pilot work we've done across multiple segments has helped us leverage further portfolio-based activity. So to summarize, to bring things back to Russell, I think what Russell would want us to do is perform more in-depth collaborative work in this space to try and iron out the variation in care we see, to try and offer our patients better outcomes, simply because there are so many things happening in this space in the oncological treatment that we really can, working collaboratively, offer patients better outcomes and longer survival. And with that, thank you for the opportunity to speak on this topic. I'm grateful to tons of colleagues who work collaboratively with us. And this is a small proportion of people who work on this, on recurrent cancer at the IREC. I'm sorry, I got a slight cold, so my voice cut out in between. Apologies for that. Thank you again for the opportunity. I'll stop sharing slides now, Richard, if that's okay.
Thanks very much, Vin. That was really super and very impressive the way you've built that huge collaborative network. And it's interesting because at the start of our careers, these collaborations didn't exist, did they? And it is an interesting observation. We grew up with the NCRI Clinical Studies Group, and we became quite collaborative at an early stage of our career. And I just we have difficulty replacing that group, haven't we? But you've done a brilliant job of assembling that. Yeah. One question I was going to ask you, just while we're waiting for any of the questions to come in. I have tried to write papers about recurrent disease in the past, a little while ago, and I got into a tangle between second primary tumors and recurrences. And at one end of the spectrum, you might have an infield recurrence in an area that's been operated and irradiated, for example. But in another patient, you might have profound field change, throwing off lots of small primary tumors once a year for 10 years, each of which is potentially quite small. Is it reasonable to lump those in and call them both recurrent disease? Or so how do you draw your lines in the sand about including patients from large, collaborative data sets?
No, it's not reasonable at all. And we ran into this problem early on with Recut. And what we did was we very clearly said we looked at different definitions. And so that leads on to Recut Plus, which I'll come on to in a minute. So we looked at different definitions. And what worked for us was a 1-year cutoff. And there was consensus, broad consensus across the multiple centers. We recruited that 12 months is a reasonable cutoff to say it's a residual disease or it's a recurrent disease. We have specifically in that data set analyzed people who developed a primary in the radiation field, but not in the original site. So we've done that as well. There are some minor differences, but interestingly, the people who developed a primary that was not in the original site did better than those who had residual or recurrent cancer. And the key learning message for us was whether it was residual or recurrent cancer in the same site, there was no difference in prognosis. They all did well. So a message that we want to send from Recut is that even if it's residual disease, we've been classically taught that's poor prognostic disease. I don't think the data supports that. This Recut paper, and there are 2 other papers, good prospective series that don't support that contention at all. To come back to your question, we learned a lot from this, and we thought we need to look at the genomic variation within the resected cancer. So every patient with recurrent cancer who gets salvaged at the Marsden goes into Recut Plus. Recut Plus is where we sample the tumor north, south, east, west, northeast, northwest, and look at the genomic profile at each of those sites to see how much they resemble the original primary. So we'll have that information at some point in time. We've recruited 50 patients for Recut Plus, and there should be some data coming out soon.
Thanks, Vin. A question that's come in asks a narrow question about CPS score, but I wonder whether I could ask that, but also ask you to broaden the answer a little bit. So the question was, in the case that you showed for Russell, the CPS score was 20, and the implication then that it was worth having a go with pembrolizumab. And I suppose the question is, at what cutoff would you not give the pembrolizumab? I guess for us, that's driven by our funding guidelines by and large. But the broader question of how immunotherapy has changed this field for you and for your collaborations.
Undoubtedly, immunotherapy has changed this field significantly. We discuss at our MDT regularly patients who are so many X number of years down the line from immunotherapy and have a new primary popping up or something else happening. Or it could be a patient with the lung cancer and non-small cell lung cancer. They're now living longer and longer with their targeted therapy that you can pick off the shelf, and they come up with a new primary. So we are seeing them. That's certainly changed practice for us. I now see rarely did I see patients who had cord palsy diagnosed concurrently with lung cancer live for more than 6 months or so. But now it's 5 years down the line, they come back with the same cord palsy. Things are changing so rapidly. As an answer to that particular question about the CPS, it's, as you said, funding guidelines, oncologists call. If there's more than one, we would most often offer the patient immunotherapy. Pembro chemo combination is not yet NICE approved. But I think with the Cancer Drug Fund, etc., there are ways and means of getting around that. Is my thoughts on the matter.
So another question that your case raises about the treatment of oligometastatic disease or solitary metastases, and in many of our surgical oncology colleagues, particularly colorectal cancer with limited liver mets, then liver resections are fairly commonly carried out. They are also carried out in other diseases. And it's unclear what the role is in head and neck. You've shown a very positive example there. I've actually also had experience of single metastases proven to be squamous cell carcinoma, so very, very likely to be recurrent head and neck cancer, apparently cured with SABR radiotherapy. And I wonder whether you've seen reports of that in these extended, metadata that you've seen. Are people using radiotherapy frequently for isolated or limited liver metastases?
Please don't take that single message away about Russell having done so well. That's just, I would clearly show my best case. But we do see this regularly. So it needs collaborative MDT working and oncologists to sign off on this. But yes, you're right in saying I see patients who have had SABR and then who are doing well. And for other cancers, sometimes ACCs, you give them RFA and they seems to control things well for a while. Clearly, we're seeing a different spectrum of patients in the recurrent cancer setting who I think we should, just like the way the non-small cell lung cancer team do, we should be looking for alternatives for these patients and not just write them off easily is my plea, which is why the registry and perhaps having really national guidelines in this particular space would really help our patient group.
Thanks, Vin. And Terry's asked a question, and again, I think it maybe have some implications. Terry's asked about the number of UK centres that could manage that sort of workload and that complexity of disease. And I guess it comes down to the skills of the clinicians and the experience of the clinicians you need to make these sort of decisions on really complex patients.
Very true. But the other side of the coin is that when we started thinking and reflecting on how we should construct the network and how the network should be spread across the UK. One issue that was at the forefront was that people are so snowed under with primary cancer activity. They just didn't have time for this and didn't have the time to engage with this. So we thought, let's go for research active centers, which will collaborate given the research side of things. And secondly, if we went for one major center per region, that seemed to make it much more manageable, because we also had only a finite amount of money which set aside for the network. We therefore went for a relatively bigger center in a particular region to deliver this. So the figures we have, Terry, at this point in time, 9 centers, is just a figure plucked out of thin air. In terms of, to answer your question, how many do we need for the specialized workload? I think each center should consider appointing one surgical colleague to deal with the majority of recurrences, because there's a lot of learning to be had in that space. And if that one person takes the leadership in that, in managing the salvage surgery and the recurrent cancers, that will make a difference. That will be, and they will automatically, like you said, draw the work in. But I don't have any robust figures for you. If I suggested figures in this public forum, it would just be a random guess.
Yeah,
Yes,
I was going to ask. I was going to ask you. So Terry's asked about, I guess a tertiary or quaternary referrals. I mean, sometimes we like it because we can't make a mind up, and occasionally we send patients to another large MDT to sense check the decision we're considering. I don't know. What do you think about that?
So that's next on our agenda. Now that we have the consensus available now, we have 2 things we plan to do after the consensus, because the consensus was across 15 departments, as you know. So we hope that departments are agreeable to what we're proposing. Consensus done, the 2 things we're going to do are, one is to go international with the consensus, go to a few more centers, and secondly, have a national forum for discussing such things. We can't call it an MDT. MDT is a very emotive word at times. People think that MDT recommends something, that has to be the recommendation. I think some kind of informal forum to discuss these difficult cases would be useful, because there's so many oncologists who really understand the disease well, and discussing with them will really help. And I think that is the next phase of action after the consensus document. You read our minds, our collective minds.
Yeah, and I think that it's interesting, because if you deal with other oncology patients, you realize a lot of cancers are chronic diseases. And, we see patients who've got breast cancer or renal cancer who are alive 5, 10, 15 years with disease and actually have quite a good quality of life. And historically, we haven't really thought about head and neck recurrence like that. One of the challenges I find, I don't know whether you've got a view on this, is where when you first meet a patient with cancer and they're referred to you, you can be quite objective because you don't know them. So you feel responsible, but you don't have that connection. Once you've treated a patient, you've got to know them quite well. You've seen them in clinic many times, and you can't help but have a bit more of a link with the patient. And then if you do have to treat either a major complication or a recurrence, it puts you under more pressure. And I think the extra pressure never helps you as their doctor. It never helps you make the right decision, and it never helps you technically do the treatment. And I've always wondered, if something major happens, it's sometimes quite useful to lean on a colleague to help you either with the decisions or the execution of the treatment. But of course, the patient tends to link into that initial primary clinician. And I don't know how healthy it is. I don't know whether you have a view on that.
That's again an emotive question. You're right. The more you get to know a patient, as time goes on, they become friends to de-link that bond you've built with them. But you have to go for the best possible expertise available, and the only thing you can do is just crack on and offer them the best advice based on the best available evidence, and be very open and honest with your assessment of complications. And complications, something that we all worry about when we treat patients who have undergone previous radiation therapy. And the more salvage surgery I do, I think, and I've got to be delicate about how I phrase this response. So my hospital that I work in is in zone 1. premium real estate, and I'm under pressure to avoid long stay patients. And with that background, my length of stay is not huge. It is not at all. And the bulk of my work is salvage work. So I think with proper planning, with appropriate support, with a whole care package built in, we can get away with salvaging these patients, offering them major surgery, and yet getting them home within a decent period that is not too dissimilar to primary cancer surgical intervention. So I think you're right. I worry about complications, and we are cautious about explaining to them what they can expect. And we do read the full riot act out to them. But I'm banking constantly on my experience and my data, and I'm very happy to share that data to my patient and say, listen, that's the way the land lies. But our recommendation is this, having considered. But you're right, it's difficult to disentangle things.
And so the question, just to clarify, you said for the purpose of collecting this data, you drew a distinction. Did you say at 12 months? And at 12 months, you no longer call it recurrence, you call it second primary. And Dr. Sriram has asked a question. I certainly remember being taught that the peak time for recurrence for squamous cell carcinoma is 9 months, and after 2 years, it's uncommon. Of course, you always see the exceptions, but in terms of, I guess your data has to take a broad brush approach to try and capture the best value, as it were, without ever, you can never be 100% certain whether the tumor that you've considered from the literature is a recurrent second primary or what's going on. You don't know for certain, but I presume you had to take a broad brush approach about your criteria.
Good question, Sriram. We did ask people this, and the consensus when we did recut was, let's draw the line at 12 months. We had a robust meeting, a meeting like this with multiple partners across different time zones, and 12 months was the cutoff that came up. But this may become largely academic as a question, because once recut plus, if Recurrent Plus demonstrates that these are genomically different tumors you see at different time points, then we might be in a position where we're thinking, okay, we've done this, let's take a biopsy, confirm what's happening, compare with the original primary, that'll give us a better idea what exactly this tumor is. Whether it's the same tumor coming back, be it at 18 months or 22 months, or is a new tumor at 6 months.
And I think we'll make it the last question. So we've had a good discussion, but the last question, again, Terry's come in and asked a question about, I guess, is one of the themes of your research about how to consent these patients and about how that consent can be evidence-based and be balanced, and how you achieve that consent.
I'm assuming that the consent here, Terry, is for treatment, and let's focus on surgical treatment, because the surgeon asking a question to another surgeon, which is where I think the consensus document comes in handy. Generated within this country with top experts who have collaborated on this, who have given a lot of time to deliver this. I think we can go to the patient and offer them information and say, listen, this particular cancer has been through a few experts in the country, and our recommendation is this. And I think the registry, as time goes on, will complications, and you have to collect your own data about complications in this particular space as well. So it's informed consent is hard, but you can rely on the consensus process. You can rely on existing data that's been done in terms of prospective, retrospective research, and your own data set. That's the best we can do in this particular space. And that's a balance you can strike here.
Well, then we've used our 45 minutes up. I want to thank you for a very concise and thoughtful talk that's touched a lot of areas, and it's generated an interesting discussion. I wanted to remind everybody who's on the lecture that next week we're joined by our dental public health colleagues talking about the incidence of head and neck cancer and this relationship with social inequality. And the diversity of these talks and the different expertise we're bringing into this series is hopefully nicely balanced. So thank you very much, Vin, and thanks for everybody for joining us this evening, and I'll wish you good evening. Cheers now. Bye-bye.